stenosis. It can go up to about 50%. And these are what we call the symptomatic ICAS. All right, now let's look at the treatment. How then do we treat the patients with intracranial stenosis? Well, these are the patients who comes to us with stroke, and then we work them up, and then doing all these tests, imaging, vascular imaging, then we would be able to demonstrate the intracranial stenosis related or relevant to the area where the stroke happened. So it could be managed either by aggressive medical management, giving antiplatelets, maybe dual or single antiplatelets. We'll talk about that later on. And plus intensive control of your vascular risk factors. Then medical treatment could be done, and then in the vascular procedure may also be carried out. Now, with regards to antithrombotic medication, of course, the first line of choice would be aspirin. So about 325 aspirin can be given to this patient. And this has been shown by the WASID trial, wherein they compared patients who received anticoagulant, that is warfarin, against patients who received aspirin. What is of note here is that look at the aspirin. It was given as 1,500 milligrams. That's too high, right? 1.5 grams. And when we ask the author regarding this, they say that that's the one available in their country. I don't know if that's true. No, that's a 1.5 grams of aspirin. Now, the primary endpoint here is those patients who develop stroke, brain hemorrhage, or other vascular causes. Now, what was shown in this trial is that aspirin is far superior than warfarin in terms of trying to prevent the outcome, the vascular outcome. And of course, they have shown that less in adverse events amongst patients who receive aspirin compared to those who receive warfarin. So from that time on, it has been recommended that instead of giving warfarin amongst this patient, because probably they thought an anticoagulant will work on patients with intracranial stenosis, then it was a failure. It has shown that aspirin is more superior than warfarin. Now, if this patient, even with intracranial stenosis, have a high risk means previous stroke, they have some kind of coronary problem, okay, peripheral arterial disease, probably consider adding clopidogrel amongst this patient to your aspirin. But during my talk earlier regarding the combination or dual antiplatelets, we got to be cautious about this because it did prevent more vascular events, but our risk for bleeding is quite high. All right. Now, another study, and we've been involved in this. Dr. Wei Meng Chang was also involved in this. That's the CLARE study. When we took patients, two group of patients with stroke, and then by doing transcranial Doppler, we demonstrate that they're having microembolic signals. So they were randomized either to receive aspirin alone or to receive clopidogrel and aspirin. And both of them were monitored by means of transcranial Doppler, and it has been shown that those patients who received clopidogrel and aspirin have lesser number of microembolic signals after the introduction of this drug. Okay, so again, this is a surrogate outcome. It's not may not be equivalent to a clinical outcome, but indeed, because of this, we now add clopidogrel to our patients with intracranial stenosis, especially if they have risk for other cardiovascular risk factors, especially coronary artery syndrome. All right, now, the next one is adding cilostazol to those patients with intracranial stenosis. And I think this is born out of the trial by TOS, and let me see, okay. And the TOS trial, and in this trial, it's again a surrogate outcome looking at transcranial Doppler and MRA. There were two trials, actually, TOS1 and TOS2. The TOS1 was aspirin and a placebo, and they've shown that cilostazol plus placebo, and they've shown that the outcome here is whether the stenosis has regressed, has progressed, or became stationary. Okay, and especially again, as I've said earlier, that it was done in our region. So the generalizability of this amongst Asians may be really true in trying to control patients with intracranial stenosis. Well, if we look at the guidelines by the American Heart Association on the treatment of stroke and transient ischemic attacks, you will see that cilostazol was already recommended. No? Of course, we start with aspirin, and if it's high risk, we give them clopidogrel. But in my country or in our country, our practice is we give aspirin, and if there's intracranial stenosis, we start them on cilostazol. So this is the practice that we are doing in our country. And this is borne out by this trial, as I was saying. All right, as I was saying, the utilization of cilostazol was borne by these two trials, the TOS1 and the TOS2. And earlier, I said that the first one was the use of aspirin, and then after which the TOS2. We use with cilostazol, clopidogrel plus aspirin, and then cilostazol plus aspirin. So the outcome measure here, were whether we would like to know if the intracranial stenosis has regressed, has progressed, or remained stationary. Okay? Well, what the shortcomings of this trial is that we cannot equate that if they regress or if there is a stationary, that would mean that lesser in the vascular outcome. And I think that is what is important as far as this trial is concerned. But as I've said, in our country, we add cilostazol on aspirin if indeed we see that there is an intracranial stenosis. The next medication that we need to give amongst patients is really a high dose of statins. And a high-intensity statins therapy with the goal of trying to lower down the low-density lipoprotein for less than 70 milligrams per deciliter. The first trial really was done by Lawrence Wong. So unfortunately, I was looking for that particular article, and I really could not locate it. So what happened is that I tried to look at the more of surrogate outcomes on the use of statins. And in this study, they've used MRA to follow up patients and see whether it would regress, it will remain the same, or it would progress. And what they've shown that about 10% of these patients progress in terms of their intracranial stenosis, and 25% regress, and 63% remain stable. So in other words, this is again a surrogate outcome utilizing MRA amongst patients who receive statins in the management of intracranial stenosis. So indeed, it's now recommended that those patients with intracranial stenosis should receive high dose or high intensity lipoprotein statins. So another study, the Stamina MRA study, this time the first study was using MRA, but this time with the use of magnetic resonance high resolution. High resolution means trying to demonstrate by MRA the intracranial stenosis. Again, this trial has shown that giving statins indeed would be beneficial amongst patients with intracranial stenosis. Now, we try to, again, monitor or control the blood pressure of this patient in long-term situations, and we try to lower down the blood pressure to at least 140/90 among clinically stable intracranial stenosis. Although we would like to caution you not to lower down the blood pressure too much, because one of the mechanisms, as I've said earlier, amongst patients with intracranial stenosis is they may develop perfusion, low or hypoperfusion infarction, okay? Because of the sudden drop in the blood pressure, the area being supplied with intracranial stenosis is the one that would suffer, and then they develop an infarct. So be cautious in trying to lower down the blood pressure. So what we do is, if this is an acute situation on patients with intracranial stenosis, of course, a permissive hypertension in acute ischemic stroke, we don't want to lower down the blood pressure abruptly. And then for secondary prevention, of course, we all know that control of blood pressure is very important. And it has been also in the guidelines that all these patients should receive the antihypertensive drug. And what was shown in this Chinese trial or study, that for every 10 degrees of increase in systolic blood pressure, there is a tendency for also an increase in the rate of developing intracranial stenosis. And that could be shown, and this is shown in this particular forest plot, that the higher the blood pressure, the higher is the chance for this individual to develop intracranial stenosis. So again, we really need to control the blood pressure. How about physical activity? At least a moderate physical activity is being recommended. Well, what do we mean by moderate physical activity is that probably a low impact activity may be necessary. I just read this morning, before the American Heart Association is recommending 10,000 steps. But this morning I saw a news that we need only 2,500 to 4,000 steps a day. So it has lowered down our time to exercise, right? Just 2,000 to 4,000 steps a day would be necessary rather than the 10,000 they have been recommending in the past. So in this, again, forest plot, you will see the effect of the physical activity in trying to reduce the stroke risk. The relative risk reduction really has shown that it is really protective amongst patients with intracranial stenosis. Okay, the last is the bilateral arm ischemic preconditioning. And we really don't know if it still works. Number one, what I can tell you is that this is a very painful management. If you have seen this or if you have done this, very painful. So you put your blood pressure cuff about 5 or 10 degrees higher than the last systolic pressure that you would get, and then stay there for almost about 10 to 15 minutes. That's really very painful, no? Really inducing ischemia. Okay. So what they have shown is that in the upper limb ischemic process preconditioning, they were able to do it on 68 consecutive cases, and they shown that the way to improve cerebral perfusion. So by ischemic preconditioning, they've shown that it improves cerebral perfusion. So probably that would really work, and it would reduce recurrent stroke in patients with acute ischemic stroke. And lastly, I think you talk about the endovascular and surgical therapy. And for 70 to 90% stenosis, again, we would repeat that the percutaneous transluminal angioplasty and stenting is not yet recommended as initial treatment. Okay, so we don't recommend PTAS amongst patients with intracranial stenosis. Even for patients with 50 to 69% stenosis, still is not yet been recommended. And this is borne out by this trial. This is the SUMPRIS trial, and then wherein they group 2 patients with extensive medical management, and the other one extensive management plus your PTAS, or percutaneous transluminal angioplasty and stenting. And what they have shown is that the outcome amongst patients in the medical group is much less than those patients who were stented. So it seems from this trial, we've shown that putting patients on extensive medical management at this point in time is much better than having your patient stented. Okay, so as I've said, although there are certain group of patients that really need to get stented, probably we could consider that. We all know that here in Vietnam, you have able to accumulate a good number of patients who were stented, and I don't know if you try to join the WIB registry, and probably if not, you need to be able to register your patient there, and we will have more experience on stenting amongst patients with ICAS. And lastly, I think we There are ongoing trials which we should be aware of. We have the riser for dyslipidemia, and by reducing intracranial atherosclerosis with the Repatha, which is a evolucumab drug, and it is being introduced and an ongoing trial. And secondly is the Captiva, which is a comparison of anticoagulant and antiplatelet therapies for intracranial vascular atherosclerosis. Reminds you something? Yes, it's the WASID, right? The anticoagulant versus the antiplatelets. And lastly is the Convince, again, because of the anti-inflammatory effect of colchicine, because inflammation is also being invoked on intracranial stenosis. So probably by trying to reduce the inflammatory reaction going on in that particular stenosis vessels, you might be able to reduce also the recurrence. And lastly, we wait for the endovascular and surgical trial going on. Endovascular is still the PTAS, and then surgical, whether the anastomosis of MCA, ACA will still be effective or not. So we wait for that particular trial. So with that, ladies and gentlemen, thank you very much for your kind attention.